Hey guys, welcome back to it. So today we are talking about personality disorders. So before we get into what the disordered version of this is, let's take a minute and talk about what personality is. In a nutshell, personality is an assortment of adjectives that are used to describe someone's typical behaviors or traits. For example, you might describe someone as being outgoing, optimistic, condescending, or untrustworthy. These adjectives may be grouped as to whether they're describing a person's stable or temporal traits. Temporal is a fancy word for temporary, or traits that might only apply to certain situations. So, for example, Juan, who is usually even tempered and easygoing, becomes emotionally unstable whenever he is under stress. The stable traits are going to be the focus of diagnosis. So in this case, if this were a patient we were working with, we would not specifically attend to the fact that one becomes emotionally unstable in certain points in time. It's typical for people to adjust their reactions or for reactions to vary according to circumstance. But personality and the focus of diagnosis is really going to be a person's overarching traits. They're traits that remain stable and consistent across time and across situations. That being said, personality does sometimes change somewhat as a person ages. Um, for example, traits like conscientiousness, how hardworking a person is, those traits tend to increase as a person gets older. But for the most part, once a person enters into adulthood, their core personality is more or less stable. So, what is a personality disorder? A disorder is an assortment of culturally deviant traits causing distress or impairment. A catch here, and a catch that is reminiscent of what we talked about in going over the bipolar disorders, is that the distress or impairment in these cases isn't always caused to the individual. In fact, it's typically not caused to the individual and is more frequently caused to others, meaning that the individual with the personality disorder is not personally distressed or impaired by their personality, but that their personality is distressful or impairing to others. And again, this is somewhat similar to what we talked about in going over the bipolar disorders. When a person is actively manic, they may be very unlikely to report being actively distressed or impaired, but that distress or impairment may be impacting others or may be extremely evident to others. Another hallmark of the personality disorder, in addition to those culturally deviant traits, is that the personality is more rigid and inflexible compared to a healthier personality. So, going back to that example I gave you earlier of Juan, he has those stable traits and those temporal traits. And while we diagnose on the basis of those stable traits, it's healthy and normal for a person's personality and demeanor to fluctuate across situations. For instance, it's typical and normal, and again, healthy, to have a personality that you display with friends, family, loved ones, and then to have maybe a separate personality or approach that you utilize in a classroom setting or at work. Um, that's healthy to be able to gauge your environment and adjust what you're doing based on circumstance. Someone with a personality disorder, however, may be less able to do so. And so these culturally deviant traits are on display consistently. They're not really able to reel these in situations where the traits may be even more inappropriate, for example, a work or a school setting. The final piece is that we always want to make sure that a person is at least 18 before we diagnose a personality disorder. This piece goes back to what I mentioned earlier about personalities changing somewhat as a person ages, but for the most part being relatively stable as a person enters adulthood. So we really just want to make sure that we're not basically misdiagnosing like teenage angst, for instance, and that we're certain if these traits are truly disordered that they're persisting into adulthood and that they are not just naturally going away with age, in which case a disorder would not be indicated. The DSM broadly divides 10 personality disorders into three clusters based on theme. Cluster A is the odd or eccentric cluster. I also like to think of cluster A as a series of precursors to schizophrenia, in that the three disorders in this particular category all share characteristics with schizophrenia. Furthermore, while not all of these become schizophrenia, it is possible for someone to start out with one of these personality disorders and then to later on develop additional symptoms, eventually developing schizophrenia. The three disorders in this category are paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. We will not be discussing these disorders today. Today we're focusing in on just 5 of the 10, but you should know what cluster A stands for and the names of the disorders that fall into that cluster. Cluster B is going to be the main focus for today. This is the dramatic, emotional, and erratic cluster. This is my personal favorite, and this is really the cluster we're going to be focusing on today. Beyond it just being my favorite one, there are also some notable personality disorders here as well. Specifically, we'll be reviewing borderline personality disorder, histrionic personality disorder, narcissistic personality disorder, and finally, antisocial personality disorder. On the topic of antisocial personality disorder, we will also deviate into the criminal justice territory, specifically talking about insanity pleas. Cluster C is the anxious or fearful personality cluster. And in here, we've got avoidant personality disorder, dependent personality disorder, and finally, obsessive compulsive personality disorder. We will also be talking about obsessive compulsive personality disorder today, though not the other two. The main reason for that is that there are a lot of similarities between OCPD and OCD, and people will commonly confuse the two. And so I think it's important that you guys know the difference. So we will be talking about OCPD as well. Okay, so cluster B is up first. First up in that cluster, we have borderline personality disorder. Borderline personality is defined at its core as a pervasive instability in interpersonal relationships, self-image, and affect. So that's kind of the central piece. For each of these disorders, I'll define kind of what the central focus is, and then I'll also share with you the additional associated symptoms. But to kind of keep all of these separate, I highly recommend kind of focusing on the core of these disorders in terms of memorizing and learning these disorders' definitions, and then kind of tagging on the additional symptoms. So here, instability is really kind of the word to think of. And that instability, again, impacts 3 areas: relationships, self-image, and affect or mood. In addition, we're looking for 5 or more symptoms exhibited consistently. One such symptom is some degree of experience with abandonment and the avoidance of abandonment. This abandonment can be real or imagined. So this person may have been abandoned by like a parent, for instance, at a younger age, or it may be imagined, but whether it's real or not, abandonment plays a huge role in this person's life today, and they're actively trying to avoid being left again. The unstable interpersonal relationships, meaning that, a person may be very hot and cold with others. Same thing with self-image. So this person may be feeling very good about themselves and then shortly after feeling really poorly about themselves. We may see damaging impulsivity in 2 or more areas. So this could include substance use, this could include driving, this could include risky sexual behaviors, this could include risky spending types of behaviors, anything like that. It has to just be impulsive in nature, so relatively little thought given to the behavior, and the impact ultimately carries consequences and is damaging. And again, in order to check that off, we need to see it in 2 areas. We may see recurrent suicidal or self-mutilating behavior. So while we've established that suicidal thoughts and behaviors can impact any diagnosis in the DSM, it's really not listed as a symptom for many disorders. And pretty much the 2 that we've covered at this point in this class are borderline personality, and then of course major depression. So here, though, one of the differences is that we're not just talking about the ideation as we did in the case of depression. Here we're talking about behavior. So recurrent suicidal behavior or self-mutilating behavior. The difference would be that suicidal behavior is aimed at suicide as a potential outcome, or the behavior is driven by suicidal thoughts, versus self-mutilating behavior could potentially be non-suicidal in nature. This would be someone who, for instance, might be cutting or harming themselves. The aim of this behavior, though, is not death, but pain relief, or the feeling and the sensation of the behavior. We may see affective or emotional instability, meaning the person may feel very up, very down, kind of all over the board. And it's really this piece that causes many folks to confuse borderline personality with a bipolar disorder, which we'll talk about here in a minute. We may see chronic feelings of emptiness. We may see inappropriate or intense anger, where a person just is very irritable and gets very hot very fast. We may also see temporary or transient paranoid or dissociative types of symptoms. So paranoia, you guys already know what that is. We established that in talking about schizophrenia and kind of delusional type of thought. Dissociative symptoms would be someone who is kind of dissociating or separating from reality or from their sense of self. And remember, though we didn't really talk about many dissociative disorders in this class, we did talk about one recently, dissociative identity disorder. So again, instability impacting relationships, self-image, and affect, manifested by at least 5 of these symptoms. BPD is commonly confused with the bipolar disorders. As I mentioned before, the main reason goes back to that affective instability. And when people think bipolar, they think someone who has emotional kind of lability, someone whose emotions are all over the place. And while that is true, I want you to remember the criteria associated with the bipolar disorders. They are actually very stable in nature when you really think about it. You know, a manic episode has to last at least 4 days. A hypomanic episode, has to last 4 days. A manic episode a week. A major depressive episode 2 weeks. And so that's actually very stable for a person to stay in that mood that long. Here, we're talking about someone whose instability with respect to their relationships, their self-image, or their emotions, that can change in a matter of hours, a matter of days. It's very, very fast. And so when people think of someone as being bipolar and being all over the place, or when people colloquially use the word bipolar to refer to things like the weather or other constructs like that, that vary very quickly, ultimately what they're more closely referring to is borderline personality. So it's important that you guys be able to distinguish the difference in this class. And to help you with that, I would suggest pausing and watching what it's like living with borderline personality disorder. In this video, we will hear from a young woman talking about her own experience. She's also going to talk a little bit about the diagnosis process and how borderline and the bipolar disorders are frequently confused for one another. Up next, we have narcissistic personality disorder. For this individual, the core is going to be a pervasive grandiosity, need for attention, and lack of empathy. And again, this is going to be manifested by 5 or more of the symptoms on the right. First up, we've got a grandiose sense of self. We introduced the idea of grandiosity in reviewing the bipolar disorders. To recap, that's going to be someone who has a very inflated sense of self. They feel really, really good about themselves. They may be preoccupied with fantasies of more, so more money, more beauty, more brilliance, just more. They may believe they are special or unique. They may require excessive admiration from others. They may be entitled. They may be exploitative interpersonally, so use others to get what they want. In this vein, they may also lack empathy. They may be envious of others who have things that they want, or believe that others are envious of them. They may also display arrogant or haughty behaviors or attitude as well. So for some of these personality disorders, the disorders that are not supplying a real life example or greater discussion, I'm going to provide media examples as a way to kind of highlight further what the disorder is. One of the reasons I like to use media examples in the personality disorder lecture, whereas I don't really use media or fake examples in my other lectures, it's because once you really wrap your mind around the personality disorders, you'll realize that these are character types that writers like. They pop up in the media a lot. And so I find media to be kind of a helpful teaching tool in introducing these constructs to students. So the example I always give of narcissism is Walter White from Breaking Bad. For those of you who aren't familiar with this show, we basically have a high school chemistry teacher who is diagnosed with cancer. And to pay for his treatments, he begins cooking meth with a former student. However, his success was never enough. He eventually gets enough money to pay for his treatments. He actually eventually is cured of cancer. So theoretically, there's no point for him to continue. But enough is never enough. He is very full of himself. And to his credit, he is an intelligent person, which highlights something interesting about narcissism. Sometimes you'll see narcissistic folks who really aren't that big of a hot shot. Like there's really not that much for them to be grandiose about. And in some ways it's easier to kind of spot those narcissists because the grandiosity is very obvious in that situation. But it's also possible for someone who is skilled, talented, gifted to also be narcissistic if they're also kind of proportionally a little bit too full of themselves. So even though he's very smart and talented in this area, he's still believing that he's never going to get caught. There's nobody out there, either on the drug side of things or the legal side of things, who's kind of on this level. Because of that, he never really settles for average offers. He uses and abuses his poor partner and his family. He really only cares about himself, and he believes he's above the law and will never get caught. Histrionic personality disorder is going to be at its core an excessive emotionality combined with attention-seeking behaviors, again, manifested by 5 or more of these symptoms. The person is typically uncomfortable when they're not the center of attention. They may display inappropriate sexually seductive behaviors as a way to interact with others to potentially get what they want, which would be attention. They may display rapidly shifting and shallow emotions. So someone who is kind of mirroring or mimicking their emotion to kind of mirror someone else's. Their emotions may also be just described as shallow. They may use their physical appearance to draw attention. Their speech may be shallow. They may be very dramatic. They may be easily suggestible or described as gullible. And they may also consider relationships to be more intimate than they are. So upon meeting someone for the first time, may describe that person as one of their closest and nearest and dearest friends. You'll see a lot of these types of characters on reality TV shows. Same goes for narcissism that we talked about earlier. One more kind of, I guess, big character type example, though, is, of course, Derek Zoolander. For those of you that aren't familiar, Derek Zoolander's character played by Ben Stiller. He is a male model. He always needs to be at the center of attention in both of the movies. At the opening of the original movie, he accepts a modeling award that he didn't win. He's so in his head and assuming that he won that he doesn't even hear that the announcer very obviously calls someone else. He automatically assumes that other people are interested in him sexually, so he thinks that everybody else really likes him. He speaks in a very shallow and dramatic way. For example, saying, "Have you ever wondered if there was more to life other than being really, really, really ridiculously good looking?" He's very dramatic and highly suggestible. One of the plot points, the main plot point of the movie, is that he was almost hypnotized and influenced into killing a prime minister. I will point out that some critics of splitting narcissism from histrionics will argue that these are really just kind of sexist counterpoints of one another. Both of them entail some attention seeking type of behavior. With narcissism, we've got that need for admiration. With histrionic, we've got that kind of outright attention seeking behavior. But that narcissism is combined with more hypermasculine ways of gaining attention by kind of peacocking and being very grandiose and stepping all over others to get that admiration and to get that success and that glory. And so we've got that lack of empathy there. Excuse me. With histrionic personality disorder, though, we've got that kind of hyper feminine way of getting attention, which of course is going to be excessively emotional and sexual in nature. So very similar, but we're ultimately kind of pursuing that attention in two different ways. And despite the criticism, they are two different disorders. So you guys should know the differences. Finally, within cluster B, we've got antisocial personality disorder. At its core, this one is a pervasive disregard for and consequential violation of the rights of others. Because this one is so severe, we're really only looking for 3 or more of these symptoms versus 5, which include a failure to abide by the law, regular deceit of others, regular impulsivity, regular irritability or aggression, a reckless disregard for the safety of others. So someone who's basically going to do what they're going to do, regardless of how it impacts others, specifically others' physical safety. Someone who is regularly irresponsible. This could relate to finances. This could relate to work. And someone who regularly lacks remorse after hurting or mistreating another. And I really consider that last one to be kind of the hallmark kind of symptom of the antisocial type. This one is a little bit interesting as far as age goes, because while we're still not diagnosing until the person's 18, with antisocial, signs and symptoms should be evident from a younger age. Specifically, we should be seeing symptoms, maybe not necessarily a full 3, but we should be seeing some symptoms at least since at least the age of 15, although probably you'll be seeing indicators at an even earlier age. The person could have been diagnosed with a conduct disorder prior to the age of 15. Conduct disorder is something that we will talk about more next chapter. Conduct disorder will be covered in the childhood chapter, so we'll come back to that one. But if conduct disorder is not diagnosed, we should be seeing indicators of conduct disorder prior to age 15. Meaning that because of the person's life circumstances, they might not have popped up on someone's radar until they were 18, 20, 21. And so there might not be an existing diagnosis that was in place when that person was 15. But this shouldn't prevent you from moving ahead with a diagnosis of ASPD now that the person is 18. Instead, we simply just have to look at their history and determine, okay, even though conduct disorder wasn't diagnosed, there are clear signs and symptoms of either conduct disorder or full-blown antisocial personality prior to the age of 15, even if neither one of those things was diagnosed. I do want to point out that not all conduct disorder turns into antisocial personality disorder. Some folks grow out of it, some people don't and end up developing antisocial. But again, we'll talk about that more next time. Okay, so now we're kind of deviating a little bit from diagnosis, and we're going to talk more about specifically antisocial personality disorder and the legal system. One of the reasons I chose to highlight the legal system here is because when we think antisocial, I mean, if we go back to the criteria, we've got a lot of things that are breaking the law, failure to abide by the law first and foremost, but then a lot of these other symptoms kind of imply law breaking, like not regarding the safety of others, hurting or mistreating others, irresponsibility, deceit. And so there's an obvious intersection between ASPD and legal system. Beyond that, I do know that some of you guys are CJ majors, and so I like to kind of incorporate major relevant topics for common majors that frequently take this class. So In that vein, we're going to be talking a little bit about the insanity defenses, which, even though, again, I included this for CJ folks, I find that most students are interested in this content. So up first, I want to introduce a new term, the psychopath. This is probably a term you've actually heard of more than antisocial personality disorder. A psychopath is a legal term implying someone with ASPD who is also violent. So it is important to know that there is a difference between ASPD and psychopathy. Namely that antisocial is a clinical term, psychopathy is a legal term, and while they're similar, they're both kind of implying ASPD at its core. Psychopathy is implying that violence, versus someone with ASPD isn't necessarily violent. Again, I'll show you the criteria again, and there's obviously law breaking here, but depending on what symptoms a person has, we may not actually be hurting other people. And so not all folks with ASPD are violent. So it is important to distinguish psychopathy as the specifically violent type, and simply ASPD by itself as something that could be violent, could be nonviolent. Someone who is criminally committed is someone who is institutionalized against their will when it is believed that a mental disorder is what is causing a crime. Broadly speaking, this is referred to as the insanity defense or the insanity plea. In reality, though, there are three variations on this general term. One is when someone is found not guilty by reason of insanity. A second is when a person is found guilty but mentally ill. And a third is when a person is found incompetent to stand trial. And yes, we will be going through each of those three and discussing the differences. Again, I also do just want to point out that ASPD may also exist non-violently. I like to refer to this as the white collar type, typically because the crimes these folks commit are frequently referred to as white collar crimes. So the law is still typically broken, but there is no violence. No one is physically harmed. An example of this might be like Bernie Madoff or someone who is behind like a Ponzi scheme. So again, it's important to encompass those folks in your mental schema of ASPD, and then reserve the term psychopathy for those who are violent offenders. Okay, so up first we've got not guilty by reason of insanity. This is when a crime is committed due to a mental disorder, preventing a person from grasping the illegality of their actions. So I want you to really think about this phrase. Someone whose disorder is preventing them from grasping the illegality or the reality of what they're doing. When you think about ASPD, and again, I'll flip back again, I promise this is the last time I'll flip back. If you think about ASPD, this is someone who is disregarding, violating the rights of others. There's nothing really in here that indicates this person is out of touch with reality, or that this person doesn't really understand that what they're doing is illegal. So this doesn't really apply to folks with ASPD. Folks with ASPD frequently do not legitimately fit criteria for NGRI. They may try to appear as if they meet criteria for NGRI, but legitimately they typically don't. There is, however, a diagnosis that we've talked about, and I'll give you a hint. We talked about it really, really recently, but there is a diagnosis that we've talked about that typically does describe someone who is out of touch with reality, someone who may interact with the law, and it's more frequently this person who ends up potentially utilizing this plea. So I want you to think about this a little bit more. There'll be obvious hints to it later on in this lecture, but we'll talk about this a bit more in class. But again, something we talked about very recently, and something again that there'll be very obvious hints to here in a minute. But think about what disorder really more likely applies to this statement, that someone would really not understand the legality of their action. NGRI is not allowed in every state, so this is not a federal plea, this is a state level plea. Ultimately, it's only used in about 1% of felony cases, so it's extremely rare. And it's only successful, someone is only found not guilty by reason of insanity in only about 15 to 25% of those 1% of cases. So very, very rarely is it used, and even more rarely is it successful. It's really important to point that out because one of the biggest myths about this insanity plea is that it's just used willy-nilly. It's used all the time. People are committing crimes and they're walking. That is just simply not the case. And even when people do successfully use this plea, none of them are just set free. Instead, they would go through a civil process of being committed to a hospital versus a criminal process of being sentenced to a prison sentence. Insanity is a legal term that's used when someone has been evaluated and determined to have a mental illness. And so that is where this legal term comes into play. So insanity is not a clinical term, it's a legal term. It basically, again, means someone has been evaluated, assessed for mental illness, and it's been established that they do have a mental illness. So someone who is legally insane is someone who has gone through, again, this assessment process, specifically in a legal setting. So a lawyer has subpoenaed a mental health professional to conduct the assessment and kind of share the results, whether or not the person has a mental illness. In this case specifically, the mental illness either impacts the person's ability to understand the legality of their actions. So the mental illness contributes to the person not understanding that their actions were wrong, or the mental illness contributes to the person not controlling their behavior. So those are kind of the secondary pieces. So insanity equals established mental illness that causes one of these two things: the person not understanding that their actions were wrong, or the person not being able to control their actions in the first place. And so this definition of insanity differentiates an illegal act from a crime. Specifically, a crime requires criminal intent or mens rea, which is Latin for guilty mind. So in this sense, it is possible for someone who's declared legally insane to commit an illegal act, but it is impossible for them to commit a crime. Because for a crime to be committed, a person must understand that what they did was wrong and have understood that in the moment, or they couldn't control what it is they were doing. And so for someone to be found not guilty by reason of insanity, they have to be in one of those states that allows it in the first place. And then they have to be declared legally insane, which would prevent them from being charged as guilty of committing a crime. Instead, they would be found not guilty by reason of insanity, meaning they committed an illegal act, but not a crime. Famous cases, so I'm a bit of a true crime fan, so I'll be sharing famous cases for each of these. Up first, we've got John Hinckley. He was stalking Jodie Foster several decades ago, who's an actress some of you guys may be familiar with. And in doing so, he actually attempted to assassinate President Reagan. He did not, of course. He was found not guilty by reason of insanity and was hospitalized for 30 years, and was actually released relatively recently in 2016. So one thing you'll notice about Hinckley is that he was hospitalized for 30 years. So when I say people are not set free, I mean it. They are simply shifted to the civil process, and frequently the hospital stays that result from that process are as long, if not longer, than the length of time a person would be sent to prison. Eric Clark is another example. He killed a police officer, believing that the police were aliens. So he, definitely, in my opinion, if we're thinking about insanity, definitely didn't understand where he was, what was going on when he killed this police officer. However, because he killed this police officer in Arizona, which is a state that does not have an NGRI plea, he was found guilty and sentenced to 25 years in prison. Up next, we have guilty but mentally ill, or GBMI for short. This is when a mental disorder is found to be present, but it doesn't change the criminal responsibility. So criminal guilt is implied here, and thus this person is subject to criminal versus civil penalties, meaning this person is going to prison versus someone with an NGRI that we talked about on the previous slide. As I mentioned, they're going to be kind of shuffled or shifted to a civil proceeding, which would result in a hospital stay instead. One of the reasons that GBMI was established was to address public concerns relating to the not guilty by reason of insanity plea. At the end of the day, though, as I've established, this is already an extremely rare plea, and it's successful not that often as well. So it's really kind of a myth, again, that NGRI is used super frequently, because it really isn't. At the end of the day, creating this guilty but mentally ill category didn't really reduce the number of NGRIs, but in large part, that's an incidence problem, meaning that it's really hard to decrease something that's already really rare to begin with. So the idea here is that, the public's concerned that people are committing crimes and then just getting off, so to speak. And so this was created as a way to basically acknowledge that folks were mentally ill, but to not actually change the outcome. So people are still going to be criminally guilty, found guilty of crimes versus legal acts, and be sentenced to criminal penalties, i.e. prison. Ultimately, at the end of the day, though, this person is functionally found guilty. I mean, it doesn't really change the outcome. It just kind of adds this asterisk to the end of their name that you're still guilty, you're still going to prison, but, oh yeah, by the way, in parentheses, there's mental illness here. Ultimately, one of the biggest problems with this is that people who obviously have mental disorders aren't really going to a place to be helped. This again is directing folks to a prison versus a hospital, and they're not insured mental health treatment while in prison. So it's not like they're going to a prison, but they're getting into some type of program. They're just going to prison like anybody else. And there may be programs there, depending on where they go, the level of prison that they go to, but it's not something that's insured or promised or pursued. This is problematic because it's basically just kind of criminalizing mental illness versus treating it for what it is. And in a way, this has contributed to patients who were released from asylums via deinstitutionalization just being picked up for random crimes and really being funneled into the prison system instead, because as I mentioned last class, there wasn't really a replacement for institutions or asylums, which has just contributed to that population being homeless or potentially ending up in prison, as in these instances. Okay, last but not least is going to be incompetence to stand trial. This is going to be when someone is impaired to the extent that they cannot assist with their own legal defense. So this means that someone is unable to understand court proceedings and that they're also unable to consult with their lawyer in a meaningful way to assist in their defense. So it's kind of like they're not able to help their lawyer. They're kind of a liability to themselves. Psychosis is frequently the finding of such evaluations. So in 77% of these cases, psychosis is the reason for incompetence. And so what happens is that a person is referred to psychiatric or inpatient treatment to restore competency for a later trial. And this has about a 50% success rate. So again, the person is not let off or let go, but instead they go to treatment, and it's only once competence has been restored that they return to trial to sit for their trial. You may be wondering what happens to the other 50%. So if 50% go back to trial, what happens to the other 50%? They're basically indefinitely in treatment, trying to restore competence, and their competence is being evaluated every 6 months. But if they're never meeting competence, the only way for them to get out of that cycle would be if their charges were dropped. This does bring up some ethical issues. Should we medicate a person against a person's will? So if a person's found to be incompetent, they're kind of routed to a psychiatric treatment facility, and the provider there is like, okay, this person needs medication, but the patient, in this case, the defendant, doesn't want medication. What do we do? Do we prescribe it against their will? What do we do? In a regular hospital setting, so like you go to the emergency room, or maybe you're going to the hospital more purposefully for like a scheduled surgery or something like that. It's up to the patient whether or not they want medication or any course of treatment, unless during the course of a patient's stay they pose a danger to the staff or other patients. In this case, they may forfeit their right to consent to treatment. Um, However, in this particular situation where we're dealing with defendants who are being routed to psychiatric treatment facilities, that kind of changes things. If there is no less intrusive means available and it's believed that medication will restore the patient's competency and their safety, then yes, the person can, at the end of the day, be medicated against their will. And again, even in these circumstances, only about 50% of folks have competency regained and returned to their trials. Famous cases include David Mitchell. He was a kidnapper who famously sang during his trials. He was found to be incompetent. Later, through evaluation, it was found that he was faking, so he was engaging in fictitious behaviors, and his incompetence finding was reversed. So he was found to be competent but fictitious, and he was sentenced to 1 life sentence for kidnapping. Another example of this is Kenneth Bianchi, one of the Hillside Stranglers. He faked multiple personality disorder, or DID, and through his evaluation, his evaluator actually kind of tested him with various prompts to see what he would do. So he would say things like, oh, it's really interesting that you only have like 2 personalities. It's more typical for someone to have like 4 or 5. And then magically he would start kind of developing more and more personalities. And so through prompts like that and kind of tests, it was basically found out that this guy was also faking, so he was also exhibiting fictitious behaviors, and he was eventually found guilty and sentenced to 6 life sentences. So one difference between this one and the 2 prior is that the 2 prior are kind of end stage rulings, that the person is found either not guilty by reason of insanity or guilty but mentally ill, and that's kind of the end of it. This, though, is kind of more of a holding pattern. This isn't the end. This is just something that happens in the middle of a trial where a person is found incompetent and then is regularly tested for competence. And again, as I said earlier, this is a cycle. It's an ongoing process. The person is not let go. They either return to trial when competence has been restored, or if not, they are just endlessly tested for competence. And the only way they would be released in that particular situation would be if the charges were dropped. As I mentioned earlier, I am a true crime fan, big fan of My Favorite Murder. And so for this class, I have reviewed a criminal proceeding, specifically the criminal proceeding of a guy named Gregory Murphy. You will find a description of his case on As You Learn, so I won't read that or share any additional details with you here. But in a nutshell, it is a fascinating criminal proceeding in that it's got lots of twists and turns. It's obviously got mental illness kind of muddying the picture. But I would like you to read the case, obviously, and just kind of think about it a little bit more. Specifically, I'd like to know your feelings about the case, feelings about the defendant, feelings about the victim, and some questions I'd like you to consider would be, should a person with a serious debilitating mental illness be medicated against their will in order to stand trial? I want you to, in thinking about this, weigh the right of the patient to refuse treatment versus the right of the family to have justice and closure. And also think about what would change if Murphy was able to stand trial and had been sentenced to life imprisonment or death. Would that change anything for the family? Would that change anything for Murphy? Would that change anything for Murphy's prognosis? So, fascinating criminal proceeding. Take some time either now or at the end of this lecture to read it over and consider some of these questions. Okay, last slide, last disorder, shifting gears away from criminal justice and back to kind of clinical issues. So we've got obsessive compulsive personality disorder, OCPD. The core of this one is going to be orderliness, perfectionism, and control, typically at the expense of flexibility and efficiency. And this one's diagnosed by the presence of 4 or more symptoms, which include a person who is preoccupied with the rules. So black and white thinking is very common for this person. They may have perfectionism that weirdly enough interferes with task completion. So this person is so focused on like the font and formatting of a document that it prevents them from like writing the paper in the first place. They may be excessively devoted to work and productivity. They may be inflexible when it comes to morals and ethics. So again, there's a right and a wrong, very black and white thinking. Weirdly enough, they may be unable to discard worn out or worthless objects. So I've always found this to be the odd symptom, and that you would think if someone's very clean, perfectionistic, that, you know, they wouldn't just have kind of this hoarding almost type of tendency that, you know, is not taking over their whole living space, but may encompass like a closet or storage unit. Um, Really, where the symptom comes from is a desire to be prepared, and to not get rid of things because you might need them eventually. This person may be reluctant to delegate tasks because, you know, they've got their way of doing things and their way is the way, and, you know, you're not going to do it right. They may have a frugal spending style, meaning, and they may also be perceived as rigid or stubborn. Great example of this is Monica Geller from Friends. She is always cleaning. She's even cleaning her appliances in that one image I have there. She's got that junk closet that makes it its appearance in that one episode, where she kind of stashes a bunch of old stuff. But then when Chandler asks, like, oh, sweet, so I can put my crap in here too, she's like, no, like, you'll mess it up. She doesn't let others help. She doesn't let others help her clean or cook. And she has very perfectionistic tendencies and her preferences for how her home is kept, and for how she cooks. You know, she's a chef, so she's got her preferences in that arena as well. This one is commonly confused with, surprise, surprise, obsessive compulsive disorder. Um, I don't have a video for this one. I would rather you guys think about this one a little bit. But I mean, you've got the criteria for OCPD here, and you can flip back and review the criteria for OCD from our previous chapter. So just kind of take a minute to kind of compare the two side by side and really list out some of the differences. In a nutshell, it kind of boils down to personality versus behavioral tendencies. But I just want you guys to think about some of the differences, and we will discuss further. If you are in one of my asynchronous classes and you're having a tough time cracking the differences here, I invite you to join one of my synchronous classes, or you are welcome to post to the discussion board or email me if you're unable to really kind of crack the differences here. All right, so that is all that I have for you guys. Hopefully you enjoyed our kind of different path today, and I will catch you guys next time.